Hello everyone. Good morning, good afternoon, good evening to you all from wherever in the world. Thanks for joining us today's webinar. And I am Anup Adhikari, pronounced Anup, and I am from Nepal. Nepal is the place where Mount Everest is located. Gautam Buddha was born. Nepal is an ethnically complex, diverse country with numerous indigenous and linguistic communities. I'm grateful to own this beautiful land of indigenous kin who care with sun, earth, and air. Thank you, IBP, WHO, IBP Network, Community Alliance Network, we can say shortly, CAN, and all the participants who are supporting for organizing this event and all the organizers for success for this webinar. Now, we are starting our webinar from our elders, from indigenous community. We have different cultural practice, traditional practice we have. So I want to request Yogi Adesh to start the webinar. Now, time for you, Adi.
Thank you, Anup sir. So I think everyone can hear me. So welcome everyone. So welcome to this online webinar, and we are here to talk about very important issues. So without any further delay, today I'm going to start with this grounding session for all of us together. So I would like to request everyone to be seated in a very comfortable position wherever you are. Slowly bring your awareness towards your breath for a while, as we are going to do a grounding ritual. Bring your awareness towards the sounds that is coming to this place right now. Just listen to the sounds that is coming into your room right now. Now I'm going to start the ritual. Now, I would like to request everyone to put their right hand in their heart, left hand in their stomach, and just be connected with themselves for final few minutes, few seconds. So let's take a long, deep breath from our nose. Inhale your breath, hold your breath for a while, and slowly exhale your breath out. You can take a long breath in through your nose, hold your breath for a while, and slowly exhale your breath out through your nose. Again, take a long, deep breath in, hold your breath for a while, and slowly exhale your breath out. And thank you, everyone. So we did a very short ritual to come back to ourselves, to ground ourselves in the beginning of this session, as it is very important to align ourselves in this body, in this mind, and the breath that we call it spirit. And we all offered to the 5 elements. In Nepal, we call, in Sanskrit, we call Panchadut. And we bow down to the sun, we bow down to the moon, we bow down to the earth. So for that, I'm going to say our prayers at the end of this session. So everyone, please be in your sitting, be in your heart and in your body and in your breath, and listen to this mantra, listen to this vibration. We honor you, sun, for the light and the warmth you give us. We honor you, moon, for the wisdom and the patience that you give us. We honor you, sky, for your warm presence and your embrace. And we honor you, Mother Earth, for nurturing us. We honor you, the Great Spirit, in the name of our ancestors and the Spirit guides. And we thank you for this path and this chance to grow with love. Thank you, everyone, for this wonderful setting and wonderful environment. Thank you. So next.
Thank you. Thank you, Yogi Adi. It's our ritual, different cultural, different tradition we have, and we're conducting this through this session where we started our webinar. From this webinar, we have CAN presenter, which she discussed about the introduction of the CAN Research Initiative. Then WHO discussed about the SRHR guideline. Dr. Arial will explain about the challenges, opportunity of SRHR for Indigenous people living with HIV at a local level. Maheshwar Ghimire will discuss about the sexual and reproductive health status of Indigenous people living with disability. Gyanu will explain about the maternal health of Indigenous people living with HIV. And finally, the way forward, how to operationalize this activity will be given by the Rajesh. Then we'll discuss about, jump into the discussion session, then we'll close the session. This is our agenda for today's webinar. This webinar will be recorded, and you can submit your question in your question box. From this question box, we will get your questions. Then I will read out this chat to our panelists. Then panelists will address these questions, and all our program webinar will be recorded. We can get from the CAN website is mentioned in the screen, can.ca. And also, if you are using any social media, use hashtag can_officials for this whole process of webinar. And in our panelists, just already explained about the agenda. We have lots of panelists. They are discussing from different backgrounds with different agendas. And from these agendas, we can start our webinar. Firstly, for the first presentation, I would like to welcome Karin for discuss about the CAN research. Karin, it's floor for you.
Hi, good morning, everyone. Well, it's morning here in Canada. So I'm here to just talk about the research initiative on the sexual and reproductive health and rights that we have with CAN, with the Communities, Alliances and Networks, which was formerly known as Canadian Aboriginal AIDS Network. Next slide, please. So our research project has a really long official title. It's actually called the International Indigenous-Led Mobilization of the United Nations Support Group on Indigenous Issues and the World Health Organization Consolidated Guidelines on Sexual and Reproductive Health and Rights, or SRHR, of Indigenous women and girls, leading an intersectoral response through self-determination. Next slide. But we've shortened this down to measuring the SRHR responding to the needs of Indigenous women and girls in a global context. And when we refer to women and girls, we're inclusive of cis women, trans women, two-spirit, feminine identifying, genderqueer, and non-binary. So it's a very inclusive term when we're referring to Indigenous women and girls. Next slide, please. So at the outset of our project, when we were in the first phases and we were really thinking through how we wanted to do this, it was important for us that we include ceremony and culture and tradition into our work. And for this reason, we've engaged with elders from each of the 7 countries that are involved in this project to guide us through this work in a good way. Also, Indigenous women and girls, we wanted them at the end of this project to be equipped with knowledge to help them make the best decisions for them, for their bodies. So rather than being told what is right for them, letting them decide what works and what doesn't work for them in their context. So the project will enhance the ability of these Indigenous women and girls to engage in different levels of research, and it will also strengthen our Indigenous and allied partnerships that we've already established through CAN, through the EHAC, or also IGWA, the International Indigenous Working Group on HIV and AIDS. And that's really how all of this started, was through partnerships that CAN had developed through IGWA. Next slide, please. So the research questions that we want to answer are: what are the underlying cultural and structural issues Indigenous women and girls face in accessing safe and effective SRHR? What are some cultural and structural opportunities that can increase their access to safe and effective SRHR? What are appropriate culturally responsive solutions to advance Indigenous women and girls SRHR? And this is where we're really going to rely more on our knowledge keepers, our knowledge holders, and our elders and spiritual leaders. And how do we build Indigenous men's capacity to advocate for optimizing SRHR of Indigenous women and girls? So we don't want this to be a siloed approach with only women and girls. We know that in order to improve SRHR of women and girls, we also need the support of men and boys. And so for this reason, we're going to include them throughout the research project. Next slide, please. So the project has 4 overall goals. And we're going to develop materials that are relevant at the global and local level. So everything that we develop will be tailored to the local context in which it's developed. And our overall goal is to develop an Indigenous framework that promotes and improves well-being. So the aims of this project are to investigate how to address underlying barriers to adequate data progress in SRHR, to incubate culturally informed solutions through the development of template materials with solid global partnerships. So these template materials will definitely be adaptable to different local contexts, so people can use the templates and adapt it to their specific context. We also want to mentor and train Indigenous women and girls with allied supporters in global SRHR metrics, and support capacity building among Indigenous self-identified men and boys. Again, this is inclusive of non-binary people, So they will be advocates and change agents for Indigenous women's SRHR. Next slide, please. And the deliverables, so we're going to start with a scoping review of SRHR. This will be specific to Indigenous women living with HIV across the countries. And this is what's going to form the structure of our focus groups. And these focus groups will take place in the 7 partner countries with some global questions, but also with some very specific, very context-specific questions as well. The focus groups discussions will then inform the development of a survey, and this survey again will be administered across the 7 countries, and the survey will be conducted by women living with HIV or women impacted by HIV. So we really want this to be peer-led and peer-informed. Finally, an Indigenous appropriate toolkit. We know that the word toolkit is not always the most appropriate term, and we will find a word that captures what it is that we're trying to create, but for the sake of this, we're just going to call it a toolkit on SRHR, and care for Indigenous women and girls will be created. Again, very context specific. And last, we'll do a process evaluation on the success of the project and the development of all the materials that we've developed. Next slide. So Manjula is not able to come today, but she has prepared a video for her presentation.
Thank you, Karin. Now, our next presenter from WHO, Manjula, is not right now. Just Karin mentioned that. Then we'll go through her video. Okay, we'll play our video. She are prepared for the WHO initiative, WHO guideline for the SRHR for, of women living with PAD-HIV. We'll play the video.
This presentation is really to provide a brief overview of the key principles behind the development and you know, an overview of the guideline itself. It's a consolidated guideline on sexual and reproductive health and rights of women living with HIV, which was published in 2017. And it's really the outcome of a broad consultative process that involved, you know, national, regional, global experts that included healthcare providers as well as policymakers, program managers, particularly at country level, and UN agencies, ministries of health, national AIDS control programs, and particularly many networks of individuals and networks of people living with HIV, and that included representation from Indigenous women living with HIV. So the rationale and the scope of this guideline is really because many countries, women living with HIV do not have equitable access to good quality health services. And they are also faced with multiple intersecting forms of stigma and discrimination. And we hear about these stories over and over across most of the regions that we have encountered, and the women living with HIV, particularly from resource poor settings, are disproportionately vulnerable to violence and violations of their sexual and reproductive rights. So this guideline starts from the point when women already know that they're living with HIV, and acknowledges that for those who are not aware of their status, they must first be reached by safe, voluntary, non-coercive HIV testing and counseling. So although this guideline focuses on women living with HIV, we do also acknowledge that sexual and reproductive health and rights for many women in resource-poor settings could be similar. But we are focusing here on the particular vulnerabilities that Indigenous women face with regards to being able to not only access quality healthcare, but being able to have a safe, supportive space in which their sexual and reproductive health and rights are acknowledged. Next slide, please. So this is just quickly to say that among the many leading roles of WHO is the mandate to develop high quality, evidence-based guidelines to support countries and communities. Next slide, please. And very briefly, what we mean by a WHO guideline is outlined. We do follow a process that's quite standardized, that's described in this handbook. And what we mean by recommendations are information that can be useful for policymakers, health workers, and also the end user, and in this case, women living with HIV. And it implies really a choice between different interventions. It's based on evidence, and it has ramifications for the use where there's limited resources. So there is issues related to cost and equity that come into play in each of the development of these recommendations. Next slide, please. And this guideline adopted a perspective that was, I wouldn't say unique, but that really grounded in the perspectives of women, their families, and communities. It adopted an approach that didn't start from what the expert needed to say, but what the women and the girls, including Indigenous women and girls living with HIV, had to say about their own sexual and reproductive health and rights. Next slide, please. And so some of the guiding principles are included on this slide. And first and foremost, like I said, it adopted an approach that is centered around the needs and rights of the end user of this guideline, which are women, girls, gender diverse individuals living with HIV. It really sees them as active participants, as well as beneficiaries of trusted health systems that respond to their needs, their rights, their preferences in holistic ways. It emphasizes the promotion of gender equality as central to the achievement of their sexual and reproductive health and rights. It in many ways requires that women are empowered with education, with support, to make and enact decisions in all aspects of their lives, and including in relation to sexuality and reproduction and HIV. So the guideline itself is organized around their health needs and priorities. And I'll get to this a little bit more in a minute. Next slide, please. So one of the key principles was about meaningful community engagement. So what was unique in the development of this guideline was a global survey which was conducted by and for women living with HIV to assess their priorities. And this was called a values and preferences. So it was a global survey, and some of the key aspects of this report, and this is the cover of the report, and the link is included here. So some of the key aspects was about the extent of the violence, stigma, coercion, discrimination that was systematically faced by women living with HIV, and the resulting mental health concerns. The report also highlighted the need for quality, respectful care within health facilities and in the hands of health workers, which was felt to be really lacking, in particular for those who are made most vulnerable due to their circumstances and who are marginalized or criminalized or stigmatized in any way. Next slide, please. And so this is the framework for the guideline. And you can see the same image of the house that came out of the Values and Preferences Global Survey is at the center of this guideline. We place the needs and the rights of the women at the center. And in addition, you can see in blue the health interventions around various areas of sexual and reproductive health and rights. And in purple, the elements of an enabling environment that would be needed in order to implement the recommendations. Next slide, please. The sexual and reproductive health topics which are covered in the guideline align with the WHO Global Reproductive Health Strategy. So it includes some of these areas. I'm not going to read them out, but covers areas related to maternal health, family planning, sexual health, and STI, cervical cancer, and issues that are cross-cutting, such as gender-based violence. Next slide, please. And as I mentioned, the enabling environment also becomes really critical here. And we know that there are many challenges which we've highlighted, but the guideline attempts to provide strategies in order to improve and be able to create that enabling environment in order to implement the guidelines and advance the sexual and reproductive health of women. And that includes improving accessibility to quality services, acceptability of women themselves with relation to the recommendations and the services that are available, the affordability, the equitable coverage of these interventions. Next slide, please. And so the guideline includes recommendations, both for that enabling environment, which I just mentioned, but also specific health interventions around SRHR, which we just mentioned. And you'll notice that in the guideline, each of the recommendations, each of these sections include that little house that I noted before in the framework, because the voices of the women and their priorities were included in the development and in the wording of the entire guideline. Next slide, please. So there were recommendations, but there were also good practice statements, again, for the enabling environment, such as psychosocial support, such as the need for healthy sexuality across their life course, such as the need for protection from violence and social inclusion and acceptance, and also various health interventions, as we've already mentioned. Next slide, please. So the guideline was published in 2017, and this unique process of community engagement led to it being accepted as one of the gold standards in guidelines from WHO, and the establishment of a WHO advisory group of women living with HIV. It's the only community advisory group of WHO, and it includes representation of Indigenous women living with HIV. Next slide, please. And while we recognize that there are many excellent initiatives and programs and policies that already exist in countries, implementing these global recommendations and good practice statements really needs for it to be adapted to the local context. And in our experience in implementing this guideline, the communities which need far better care are Indigenous women living with HIV, are communities that include transgender persons, migrants, incarcerated people. And again, we hear about these stories and these challenges across many countries and many regions. And so having the guideline alone is a good start, but is not sufficient. And the implementation and the uptake of these recommendations at country level requires the partnerships and the support that webinars such as these provide. Next slide, please. I just wanted to share these words from Marama from New Zealand. You know, it has really been an honor to work with so many individuals and communities living with of women living with HIV in the development of this guideline. And we really continue to look to you and our partners on the ground to help us adapt and build the guideline better. The guideline now has a living format, which is a web-based format, in which we will continue to update and keep it relevant. And as new evidence comes, including through this research project, we will continue to update the guideline so that it will continue to evolve. Next slide, please. The next slide has, so this slide has the resources, which we hope that you will feel free to use and make available. It includes community-led strategies for the implementation of the guideline and case studies that was developed by and for women living with HIV. So please feel free to use these links or reach out to me for any further information. Next slide, please. So this is just my last slide, and I really wanted to thank everyone again, and really an integrated approach to health, to human rights, to gender equality lies at the heart of ensuring the dignity and the well-being of women living with HIV. I really look forward to receiving feedback on how best we can implement this guideline.
Thank you. Thank you, Manjula, for your report. And till now, we discussed about all the issue of global issues. Right now, I would like to welcome Dr. Aryal. Dr. Aryal, floor for you.
Thank you, dear Anup sir. Yeah. Hello, namaste. Good evening, good morning, and good afternoon. It's me, Bhagwan Aryal, an assistant professor of health education at Tribhuvan University. As you see in my bio, short bio, I have been involved in SRHR, sexual and reproductive health and rights related studies in Nepal. Next slide. I'm going to discuss the challenges and opportunities in advancing sexual and reproductive health rights of indigenous women living with HIV at the local level. Universal access to SRHR is essential for achieving sustainable development. Normally, it promotes reproductive decision-making, freedom from forced violence, access to reproductive information and education, freedom from harmful traditional practices and gender-based violence, and freedom to express personal sexual orientation. So it's a concept applicable to safe sexuality and reproduction, which incorporates the rights of the people regardless of their age, gender, and other characteristics. This is the slide here where national context is given here. When I went through the literature review regarding SRHR of the indigenous women living with HIV, I found very limited data. However, the SRHR situation is not encouraging for most women in the world and Nepal. Indigenous people, particularly indigenous women, have significant challenges in realizing human rights around the world. They experience inequalities in practically every aspect of human development, including SRHR, and their rights are undervalued in mainstream development frameworks. Indigenous women and people, basically female adolescents, are at risk of HIV and AIDS due to a lack of access to sexual and reproductive health care, with economic, social, and sex exploitation. These are contributing factors despite a major data gap on sexually transmitted illnesses and HIV and AIDS. There are information-related challenges in the Nepalese context. As you see here in the slide, a total of 13,986 females in Nepal are living with HIV, comparatively lesser than males, because males contribute 16,340 in number. However, next slide, please. However, the percentage of the women of 15 to 49 years of age living with HIV is 53%. This number, the active aged female number, is more compared to their male counterparts. And this data jumps in the case of STIs in women. For example, total urethral discharge syndrome, gonococcal, is 4,131. This is the total number, out of which 3,003 females had this infection. This contributes to 72.69%. Next slide, please. So, low prioritization, there are many challenges in advancing SRHR of indigenous women living with HIV at the local level. Low prioritization of the sexual and reproductive health of indigenous women living with HIV at the policy level is the biggest challenge in advancing SRHR of individual women living with HIV at local levels. This is the foremost challenge. There are limitations in the education and health infrastructure to cover the specific needs of the indigenous women living with HIV. Although there is evidence that education plays an important role in improving sexual and reproductive health outcomes, there are issues of disparity and exclusion among indigenous women due to the inaccessibility to education. Next slide. Next, yeah. So, discriminatory practices within the indigenous community based on HIV status, gender identity, and inhibiting them from accessing health services is another challenge. So there are a lot of challenges. There also exists a tendency to blame and stigmatization of women for HIV transmission in the indigenous community. There are challenges of self-stigmatization on having STI or HIV also. This also exists here. Similarly, another issue is the low participation of indigenous women in decision making to address structural inequities. Next. The challenges continue. Challenges exist related to the development of sexual and gender-based violence and harmful practices such as child marriage, forced marriage, labor exploitation, etc. There is a huge gap in the payments to the women, and this increases more in the indigenous community, basically indigenous women. This worsens the health of the indigenous women living with HIV. There are prevailing taboos in the indigenous people. For example, not using condoms for sexual intercourse, not visiting health facilities during an illness, for example, STIs, etc., are other challenges. Studies also show that indigenous adolescents and youth experience sexual initiation earlier than their non-indigenous counterparts. There are certain studies which show this evidence. And finally, there is no specific program of research, prevention, or care for indigenous women living with HIV. This is a serious issue in Nepal. Next. SRHR is considered a human right and essential to human development and the achievement of the sustainable development goal. This is one of the opportunities. We have a lot of challenges, but still we perceive some of the opportunities as well. For example, SRHR is considered a human right in the World Human Rights documents and many different conventions. We have established this principle, this issue in the sustainable development goal. We also have an opportunity to work in this area because Nepal has committed and ratified it in many human rights treaties, including ICPD, CED, DAW, etc. New opportunities in Nepal are created due to the restructuring of the country into a federal republic nation, empowering the local levels and equitable participation of women in politics. Finally, the inclusion of SRHR issues in the national education and health related plans and policies of Nepal has also opened the doors for collaborative action in the area. Many education related documents and the health related documents have now stated the SRHR of the students as well as youths, and even it includes some issues of indigenous community. Therefore, if we focus on reducing the disempowerment and the discrimination created due to inattention in public policies, social ground, and financing, we can overcome the challenges and catch the opportunities in advancing the sexual and reproductive health and rights of the indigenous women living with HIV at the local level. So our new focus should be there to reduce the disempowerment and the discrimination which is created due to less inclusion of these issues in the public policies or in the social arenas and even in the financing sector, finance sector, so that we can overcome the challenges, the earlier mentioned challenges, and we can catch the opportunities. These are the opportunities. We have gone through a new federal system. Now, every communities are addressed by the nation, by the Constitution of Nepal. So it's the right time to work on this issue. And that's why I conclude here. We have to focus on reducing the disempowerment and discrimination created due to this inattention in our public policies, social ground, and financing. We have to anyhow overcome the challenges, and we have to get maximum from the opportunities created for the indigenous women living with HIV at the local level. Thank you, and this is much for from my side. I would like to hear from you. Thank you. Thank you.
Okay. Thank you, Dr. Ral. Thank you. You highlighted the issues of indigenous people living with HIV and SRHR. And before welcoming next presenter, I will request all the audience to, if you have any question queries, please put your question queries in your chat question box, so that I will read it out at the end of the discussion session. Then our presenter will address these questions. Meanwhile, I will like to request next presenter, Mr. Gimire, for discussing about disability and indigenous people SRHR issues, linking with the SRHR issues. Welcome, Mr. Gimire. Floor is for you.
Thank you, Anup. Good morning, good afternoon, good evening, wherever you are, all participants and presenters here. I'm going to talk about the status of sexual and reproductive health of indigenous people with disability in Nepal. And there are not much to say, as we hear about the overall scenario from Dr. Aryal. So I'd like to focus more on the disability issues. Please, next slide. Person with disability, if we come to the data that last census 2011 that come up with the 1.96% of total population, and 2021 data to come. So most of the organizations who are working for disability are not agreeing with the data, and they believe there are quite a lot, as we have WHO estimation of 15% of total population in underdeveloped countries like Nepal. So we believe on that. And based on these, even both of these data, all around the globe, we can say. And if we go down towards the indigenous population of country, it is 35.81% of total population of our country, which is about 8.5 million. And indigenous population, if we calculate based on the 15% of that, it means 1.2 million are having some form of disability. So it means there are a large number of population. And when it comes to the indigenous population, it is already mentioned in previous presentation as well, they are facing multiple discriminations. And there are, because of disability, sex, caste, and ethnicity, and in some cases in Nepal, geographical remoteness and poverty, and other few more causes are there. So we all know that discrimination creates the barriers, and it includes environmental, attitudinal, institutional, and communication barriers. And most of the person with disability, they faces this every day. Next slide, please. And these barriers leads to the poor access of SRHR information, as we earlier mentioned about that, the community who are poor, person with disabilities, women with disabilities, and if they belongs to indigenous family or population, then we can simply imagine how how much they have been facing this kind of barriers. And that also limits the training opportunities comparing to their non-disabled counterparts, and limiting or sometimes nullifying access to SRHR services. So this is the scenario. And in many cases, we heard about that the discouragement from the family and society includes in these barriers. And there are always, possibilities of assaults and violence to them. And in some cases, they are committing unsafe practices, as Dr. Oral already mentioned about that, due to the cultural and bad kind of traditional practices. And these all, as a result, consolidated and further push people towards the poor mental health condition. Next slide, please. If we see the some of the figures, however, there is no scientific data and disaggregation of data based on the disability and indigenous population. If we see some of the available data, it shows that the 13% of the indigenous women with disability reported discrimination during their menstruation, which means a very basic SRHR kind of topic. And this is what came from this study. And indigenous women and girls in far western part of Nepal are reported in risks of HIV infection due to migrant worker-based families there. So girls with intellectual disability are lead to forced sterilization, which is a very direct violation of human rights. And this is just because their families, their parents and their guardians, they just want to avoid the pregnancy, which means sometimes it can put them towards the risks of unsafe and unwanted relations and incidents of violence. So that is we are having reports in the newspapers and in some case registrations. Next slide, please. Yes, and if we see the healthcare facilities are not accessible for persons with disabilities. We were just before Dr. Ariel mentioning about the accessibility of the health services and practice of having the health, utilizing the health services. And here, when it comes to the person with disabilities, and it's more on the indigenous community, the inaccessibility is not only the remoteness. Inaccessibility is not providing any reasonable accommodation or the facilities accessible for person with disability. And it includes the lack of sign interpreters when it comes to the deaf community. And 72% of the respondent of one study that they are facing challenges to get SRHR services in normal situation, which is in the usual days. It is not about the emergencies or other scenario of disaster. So this is how it looks when we come to the data. Next slide, please. Here is what next. This is a question for we all, including me. So there is a data gap, and even available data are not disaggregated by disability. So it is always very important if we want to have some specific interventions, then we need some data. So this is one challenge we are facing. And another one is indigenous people with disability are facing multiple discrimination, and those discrimination are not addressed. So this is the reality. And there are some indigenous people living with HIV and AIDS. So there are few unanswered questions exist in our society. This question is for all. I already mentioned about if their special needs are addressed. So it is a bigger question. And are there reasonable accommodation provided? So another question. And are available services accessible? And how is SRHR services in ensuring equality and equity? For example, we are talking about the tools, guidelines, and so and so. Are those guidelines accessible for all? Are there appropriate medium we are using and disseminating those? So these are the questions. So I would like to request and call and ask that let's rethink about this slogan that we promise on the SDG, that leaving no one behind. Thank you.
Thank you, Mr. Givire. Now we explain about the situation of people living with HIV, indigenous group, as well as the people living with disability. And these are the huge issues. And we address some, we raise some questions for all. We need to think over it. नेपाली साथीहरू, हामीले यो विषयमा धेरै कुराहरू गर्यौं, तर अझै पनि यो विषयमा हामीसँग धेरै ग्याप छ। अब यो विषयलाई हामीले कसरी उठाउने भन्ने कुरा चाहिँ हामी सबैले क्वेसन उठेको छ। अब हामीले यसमा कसरी अगाडि बढ्ने भन्ने कुरा चाहिँ सोच्न आवश्यक छ। So I would like to welcome next presenter, Gyanu ma'am, for presenting on the service. We are providing the different services for different activities. Now she will explain about the maternal health service for indigenous people living with HIV. Now floor is yours, Gyanu ma'am.
Okay, thank you, Anup sir. Namaskar, everyone. I am Gyanu Maharjan of Kathmandu Model Hospital, School of Nursing from Nepal. Today, I am going to present on maternal health of indigenous women living with HIV in Nepal. It includes pregnancy, delivery, and postnatal period. This is a joyful and a crucial time of every woman's life. Next slide, please. Regarding the situation of HIV positive women in Nepal, there are 239 new HIV positive pregnant women, and whereas 90% are facing the health and the treatment problems, and 77.5% are facing violence. It includes the physical, emotional, mental, and verbal violence. And even health workers hesitate to give a proper treatment and the health services to the positive mothers in Nepal. Next slide, please. Being a nurse, I observe there is a unequal responses and the healthcare services to the positive mother. And positive women need a pay high times or the 8 times more than the normal cases when they are admitted in the hospital. And in Nepal, there is a prevention of mother to child transmission of HIV, which is the PMTCT program, is also launched. However, the health facility and the readiness to check up is very little or very low. And there is no availability of the advanced immediate neonatal HIV testing. When positive women deliver the baby, there is no advanced immediate HIV testing too. Next one, please. Next slide. This slide shows indigenous women and their health practices. In Nepal, there are so many indigenous practices, but here I'm highlighting just some few examples only. Some parts of the Nepal, the pregnant women use tight abdominal binding, which is called patuka in Nepali, and they work very heavy work during the pregnancy to minimize the growth of the fetus. And they have some myth of the doing these practices. They will think it will easy for the delivery and it will helps the decrease of the fetal growth. And some pregnant women use, which is the 76% pregnant women use alcohol, and 84% consume the jar and chang, which is called the local fermented alcohol. And they believe that if they use the alcohol during the pregnancy, the baby's eye will be looks beautiful. So they use alcohol during the pregnancy. And another one is when the postnatal period women, they avoid to eat green leafy vegetables. during the postnatal period, and they think if they eat green leafy vegetable, their neonate will get abdominal pain and green stool will pass. So they avoid to use green leafy vegetable too. Next one, please. There is a maldistribution of the human resources and unavailability and unaffordability of quality care. And superstition and the indigenous practices are major challenges in Nepal. So if we force to develop new skills and a strategy for survival, they feel reluctant. So we need a midway strategy to transformation of indigenous maternal health practices and new scientific practices. So next, please. Okay, this is a slide which represent respectful maternity care. And this program is also already launched in the Nepal, but it has a bunch of women's rights, which includes the freedom from harm and ill treatment, and confidentiality and the privacy, right to information and respect for choice, and dignified care, and equity and the equality, and timely healthcare services, and liberty and autonomy. But it is hardly implemented in normal maternity care too, or normal maternity services too. So it has a big question mark. Is this implemented in the case of HIV mother? It is a big question for all of us. So next one, please. So there is a very limited research on maternal health of indigenous women who are living with HIV/AIDS. So not any specific program has been implemented in this area. So next one. So I would like to put this question to all the panelists, participants, and organizing committees out here. And what are the strategies to address these issues, and what are the next steps? Next one, please. At last, I want to state that all women deserve respectful and dignified maternity care, maternity healthcare services. Thank you very much. This is my all references. If any queries, please at the end of the discussion session, I love to hear about it. Thank you very much.
Thank you again, ma'am. It's all about our situation about the service delivery point. नेपालमा हामी यस्तो सर्भिस डेलिभरी गरिरहेछौँ, सबैलाई फोकस हामी प्रजनन स्वास्थ्यको अधिकारको कुराहरू अरू कुराहरू छलफल गरिरहेछौँ, तर एचआईभी संक्रमित भएको महिलाहरू जुन हुन्छ प्रजनन स्वास्थ्य आउँदाखेरिको अवस्था के छ भन्ने कुराकोमा केही हामीले देख्यौँ। यो अवस्थालाई अब हामीले कसरी अगाडि बढाउने भन्ने कुरा चाहिँ हामीले सोच्नुपर्छ। वी नीड टु थिङ्क अबाउट हाउ वी improve the service delivery point throughout the people living with HIV for maternity and maternal health services. Now, I would like to welcome next presenter, Mr. Rajesh, for about the way. Just we previously we discussed about how we are implementing, conducting the research, and how it is implemented, how we are planning for implementing in Nepal. Now, Rajesh, floor for you.
Okay, namaste, Rodolapa, Lasso Popula. It's me, Rajesh Sidia. I think you have gone through my bio introduction. I will explain. I will tell you what is not there. I am a IGWA leader representing from Nepal for this research and leading this research project with the coordination of CAN, IGWA, IHAC, and so the problem stated by my colleagues here, you have seen very much. We have lots of issues, lots of problems, and when a very panic situation is, we do not have any kind of statistics data in indigenous peoples in Nepal, especially in SRHR and HIV field. And basically in HIV positive women, there are lots of issues regarding this throughout the indigenous people. So we have a third plan how we operate this. Mostly we have stated we have identified lots of problems. That's we do not have any experiences working in HIV and indigenous communities in Nepal, because since a long time we do not have any kind of operationals, or we don't have any kind of SRHR integrated program in indigenous communities. So this is one of a problem statement. And then there are a lack of self-care and self-respect, as well as self-education system here. Throughout that, we have lots of discriminations in indigenous peoples living with HIV and others. And there are uneducated services integrated with indigenous people and SRHR, and as well as HIV. So these are the issues. And certainly, we do not have any kind of awareness among indigenous peoples about the HIV and SRHR services, or the education, or some kind of a knowledge booster, we could say. So that is also a gap in Nepal. And finally, we don't have any statistic data. That's the main problem. So these are the problems, these are the areas that we have focused on that. So next slide, please. So among these problems, we are trying to incorporate, and we are trying to endorse these activities in Nepal throughout this research. So may I have next slide, please, Ados? So for that, we have identified some the major parts where they have a lack of services, where they have lots of taboos, where they have lots of discrimination, and where they have they don't have educated healthcare facilities on SRHR, indigenous peoples, and sexual reproductive health. So these are the issues. You see the red points there. We have highlighted lots of red points there. Those are the districts of Nepal where we will intervene our research project, and we will find out the data from there. So in this map, this is a map of Nepal, and we have covered all the part of Nepal, from east part of Nepal to the west part of Nepal, and from Tarai to from center of Nepal. So among these, we have identified lots of districts where we have. So from those districts, we will have collection of data, we will have focus group discussion, and we will have indigenous support group establishment there, which is the theme of our project. And then we will have indigenous women living with HIV on those areas. So may I have next slide, please? So these are the places where we will intervene. So we will mobilize the peer groups to know better understand about the indigenous communities, a problem of reproductive health, and problem of HIV, problem of stigma, discrimination, and even the social taboos there and cultural taboos there. So we will mobilize that, and then we will collect the information from there, and then we will analyze the situation of SRHR among people living with HIV and indigenous peoples, women living with HIV as well. So then we will orient the issues. What is the importance of SRHR? What is the importance of sexual reproductive health, and why we need to talk about the reproductive health, as well as HIV, and as well as stigma and discrimination. So these are the focuses we will go. May I have next slide? Next slide, please. So then we will prioritize the issues in provincial structure. Nepal is based on now provincial structure. We have 7 provinces and national level. So we will collect the data from provincial level, and then we will advocate to strengthen the SRHR program in Nepal with the government, with the donors, and with the different allies who are working in Nepal. And especially we will incorporate a disabled group who are living with HIV and who are facing difficulties in to reach SRHR service in Nepal as well. So we will provide regular information related HIV and sexual reproductive health and indigenous information all around the world. We will collect, and we will regularly provide throughout our project. And then we will sensitize the media and as well as online platforms to inform them and to provide them education and to give them the better right of information and the better right of education and the better right of treatment. So these are the focuses. So can I see next slide, please? So we need to work on advocacy level throughout the provincial government, local government, and national government to provide the right and to provide the information and to know them the exact situation of in ground. So then we will advocate for income generation, because Nepal is low poor country. Lots of people are living, most of the people are living behind the certain, and they are not able to walk of life in mainstream. So for that, to provide dignified life, no matter with HIV or no matter with sexual infection, for treatment and for dignified life, we will work for income generation activities to get better access in treatment. And then we will provide we will advocate for capacity building of services, and especially for service providers. We will target service providers who have excluded indigenous people and people living with HIV, especially women in SRHR service. Around the world, we have lots of services in SRHR and HIV, but there are no integrated service for indigenous HIV positive women and special treatment or treatment on SRHR. So these are the criteria. Next slide, please. So among these, as in my presentation, you have seen most of the bullets, and specifically I have identified and I have explained main major points. So around that, if you have any kind of question or if you have any kind of issues, I will go further it. And for Nepal, हामी नेपालीहरू, for Nepalese, नेपालीहरूको लागि चाहिँ यो SRHR द जनजातिमा हुने सेक्सुअल रिप्रोडक्टिभ हेल्थमा चाहिँ ठुलो समस्याहरू देखिएको अवस्थामा र उपचारको पहुँचको अवस्थामा नपुगेको अवस्थामा चाहिँ हामीले यो रिसर्च गरिसकेपछि चाहिँ कस्तो प्रकारको फाइन्डिङ ल्याउन सक्छौं र के समस्या छ भनेर मैले माथि प्रेजेन्टेसनमा पनि भने, हामी कसरी डिल गर्न सक्छौं भन्ने पनि भने। विशेष रूपमा यो गर्नलाई युवाहरूको एकदम उत्साहजनक आवश्यकता चाहिँ हामीलाई पर्छ, किन भन्दाखेरि युवा नै देशको कर्णधार हो र युवाले नै यसलाई अगाडि बढाउनु पर्ने भन्ने अवस्था छ। किन भन्दाखेरि अहिलेदेखि हामीले सिकेनौं भने गर्ने कहिले त, अहिले नभए कहिले त भन्ने हिसाबमा, त्यो अर्थमा हामीले चाहिँ विशेष खालका कार्यक्रम पहिलोपल्ट नेपालमा हामीले गर्न लागिरहेछौँ। यो रिसर्चबाट चाहिँ तपाईहरुको सहयोग, सबै अडियन्सहरूले चाहिँ हामीलाई सहयोग गरियो भने चाहिँ हामीले 7 वटै प्रदेशबाट 7 तरिकाको 8 तरिकाको तरिकाले हामीले डेटा निकालेर त्यसलाई क्वालिटेटिभ रूपमा ढालेर हामीले चाहिँ राम्रो खालको प्रोग्राम ल्याएर नेपाल सरकार, गभर्नमेन्ट नेपाललाई चाहिँ हामीले बुझाउँछौँ र साथसाथै प्रत्येक स्कुल, प्रत्येक कलेजेस र प्रत्येक हेल्थ इन्स्टिट्युसनहरुमा चाहिँ हामीले लबी गर्छौँ कि दैट यू हैव टु पुट अ पार्ट अफ syllabus that indigenous people and HIV AIDS and sexual reproductive health. So those we could हामीले चाहिँ जान्न सक्छौं, हामीले एड्रेस गर्न सक्छौं भन्ने कुरा हो। हुन्छ, प्लिज एनी क्वेशन, कुनै प्रश्न छ भने प्लिज च्याट बक्समा हाल्नु होला। अदरवाइज चाहिँ मेरो इमेल र चाहिँ हाम्रो टिमसँग सम्पर्क गर्नुस्, हामीले चाहिँ तपाईहरुको प्रश्न र क्वेरीजहरु सकेसम्म चाँडै डेलिभरी गर्न सक्छौं। हुन्छ, हस्, थ्यांक यू सो मच फर प्रोभाइडिङ एन्ड लिसनिङ माई वर्ड्स पेशेन्टली। Namaste, Jazalapa.
Thank you, Rajesh. We have all the issues highlighted by our presenter. Some questions are coming in my question box, and म साथीहरुलाई के रिक्वेस्ट गर्न चाहन्छु भने के क्वेशन छ भने क्वेशन राखौं. If you have any question and queries, please mention in the question box. I have some questions and I will ask this question some of our panelists. First, I will go with Ganu ma'am. One of our participants asked that in your presentation you mentioned that 8 times more payment need by the PLHIV pregnant woman. Please explain more detail about it and how 8 times more than the other people.
Okay, thank you, sir. May I speak in Nepali, or is the question from Nepali or out of country?
Okay. You can address in Nepali also. No problem.
Okay. This 8 times means when the positive woman admitted in the hospital, and she needs to pay 8 times. It means she needs to pay for the PPE, and for the not for the just this midwife, she needs to pay for the whole team, including the helper. And so PP is expensive, and including the bed sheet, when she needs to pay the for the bed sheet too, and for the neonate, and for neonate also she have to pay. And another one is for the medicine. If यदि उहाँ चाहिँ अब गभर्मेन्ट हस्पिटलमा जानुभएको छ भने हाम्रोमा अहिले सेफ मदर स्किम चलेको छ, र त्यसले गर्दाखेरि यदि उहाँ चाहिँ अब जेनरल हस्पिटलमा एडमिट हुनु भएको छ भने उहाँले चाहिँ फ्रीमा पाउनुहुन्छ सर्भिस। यदि चाहिँ अब प्राइभेट हस्पिटलमा जानुभयो भने यति महँगो पर्छ कि जुन चाहिँ अब नर्मल डेलिभरीमा पनि उहाँलाई महँगो हुन्छ। इभन अब यदि सिएस गर्ने, यदि सिजरियन सेक्सन गर्ने हो भने 8 टाइम्स त पर्छ नै। त्यसैले गर्दाखेरि चाहिँ यो कुरा राखेको। जस्तो अब पिपीको कुरा मैले भनिहालेँ, एकजनालाई मात्र नभइकन होल टिमलाई नै लैजानु पर्ने, किन्नुपर्ने हुन्छ, डक्टर नर्सदेखि लिएर हेल्परसम्मको कुरा। त्यसै गरेर बेडसिटको कुरा गरेँ मैले, त्यो ओछ्याउनुको लागि जुन हामी डिस्पोजेबल बेडसिट है, यो फेरि त्यो सुधा हामीले हस्पिटलबाट उहाँलाई किनाउने गरेको छ। त्यसले गर्दाखेरि चाहिँ यो मैले 8 टाइम्स पर्न आउँछ भनेर क्याल्कुलेटेड फर्ममा चाहिँ भन्न खोजेको हो। मैले एम आई क्लियर अर नट सर?
Okay, thank you, Gani ma'am. If any information need to add, Mr. Rajesh will add it. In the meantime, I will also add one question for Rajesh. Rajeshलाई म एउटा केही क्वेसन थप्न चाहन्छु भन्दाखेरि यहाँ क्वेसन के आयो भन्दाखेरि एकजना साथीले लेख्नु भएको छ, मेलहरूको लागि अथवा यो इफेक्टिभ कस्ट इफेक्टिभ ट्रिटमेन्ट गर्नका निम्ति चाहिँ के पोलिसी छ, के प्रोग्राम छ इफेक्टिभ ट्रिटमेन्ट प्लान गर्नका निम्ति अथवा कस्ट इफेक्टिभ रूपमा पोजिटिभ वुमनहरूलाई सर्भिस डेलिभरीको लागि पोलिसीको हिसाबले भन्ने कुराको लागि, बिकज यु आर अल्सो वर्किङ एज अ प्रिभियसली यु आर वर्किङ एज अ PLHIV नेटवर्क प्रेसिडेन्ट अल्सो, सो प्लिज एक्सप्लेन इन मोर डिटेल।
हुन्छ, ओके, थ्याङ्क यू सो मच अनुप, धन्यवाद जसले प्रश्न गर्नुभयो उहाँको लागि पनि। ओके, अलिकति म ज्ञानु म्यामको आएको प्रश्नलाई पनि अलिकति एड्रेस गरिदिन्छु। यो 8 टाइम्स मोर एक्सपेन्सिभ किन भयो भनेपछि जब युनिभर्सल प्रिकसन whenever HIV positive person will go for a healthcare treatment, it will applies universal precaution. So they have to buy all the stuff, including PPE set, including all the necessary surgical equipments, and including all the atmosphere, I mean everything, सबै चिज किन्नुपर्ने हुन्छ। त्यसले गर्दाखेरि चाहिँ 8 टाइम्स चाहिँ महँगो हुन जान्छ र साथसाथै चाहिँ त्यो बेलामा चाहिँ डेलिभरी गर्नलाई चाहिँ डक्टरहरूले नमाने, हेल्थ केयर पर्सनलले नमाने, छुन नसक्ने त्यो अवस्था भइराखेको अवस्थामा त्यो हुन्छ भन्ने कुरा हो। र यसले चाहिँ स्टिग्मेटाइजको लेभललाई पनि 8 टाइम्स ल्याउँछ भनेर भन्नु खोज्नु भएको ज्ञान म्यामले। सो ओके, थ्याङ्क यू। एन्ड अगेन अब अनुप सरको प्रश्नहरू, अनुप सरले राख्नु भएको प्रश्नमा चाहिँ ओके, नेपालमा SRHR को कुरा गर्दाखेरि सेक्सुअल रिप्रोडक्टिभ हेल्थको कुरा गर्नुभएको जस्तो लाग्यो तपाईँले मलाई। त्यो हो भने चाहिँ नेपाल सरकारले चाहिँ STI को ट्रिटमेन्ट चाहिँ निशुल्क भनेर भन्छ, उपचार पनि निशुल्क गर्ने भनेर भन्छ। तर त्यसको टेस्टहरूको कुराहरू छ, त्यसमा चाहिँ महँगो औषधिहरूको कुरा छ, त्यसमा अनि हाम्रो चाहिँ एक्सपर्ट डक्टरहरूको कुरा छ, तिनीहरूको चाहिँ सबै बेयर गर्नुपर्ने हुन्छ। र नेपाल सरकारको पोलिसी अनुसार निशुल्क रूपमा यौन रोगको उपचार भन्छ, स्टिल दे कल रोग है, डिजिज भन्छ, इट्स नट इन्फेक्सन भन्ने अवस्था छैन। तर WHO ले STI सेक्सुअल रिप्रोडक्टिभ हेल्थ भनेर हेल्थसँगै राइट पनि जोडेको अवस्था छ। तर नेपालमा चाहिँ त्यो अलिकति पर्याप्त नभएको अवस्था छ। र नेपालकै सन्दर्भमा कुरा गर्ने हो भने देयर इज अदर एजेन्सिज, हामीले फ्यामिली प्लानिङ एसोसिएसन अफ नेपाल भनेर सुनेका छौँ, तिनीहरूले चाहिँ निशुल्क रूपमा उपचार गरिदिन्छ। नेपालको जुनसुकै ठाउँमा अवेलेबल भएको ठाउँमा चाहिँ तपाईँलाई केही पनि गर्नु पर्दैन। यदि इन्फेक्सन हो भने चाहिँ तिनीहरूले सेक्सुअल इन्फेक्सनको चाहिँ ट्रिटमेन्ट गर्ने अवस्था छ। अहिले आएर चाहिँ हामीले लास्ट टाइम मात्र हामीले चाहिँ HIV पोजिटिभ वुमेनहरूको कुरा गर्दाखेरि तिनीहरूको चाहिँ इभन सर्भिकल क्यान्सरको पार्टहरूमा पनि ट्रिटमेन्ट चाहिँ केही बेयर गर्ने गरेर चाहिँ हामीले सम्झौता गरेका छौँ, त्यो पनि हुन्छ। र दोस्रो, यदि तपाईँको प्रश्न बिइङ HIV पोजिटिभ हाउ द ट्रिटमेन्ट विल एक्सेस, कसरी चाहिँ सस्तो पर्छ, कसरी राम्रो हुन्छ भन्दाखेरि तपाईँको लागि चाहिँ नेपाल सरकारले चाहिँ HIV संक्रमण भइसकेपछि ART निशुल्क रूपमा दिन्छ, सबै उपचारहरू निशुल्क रूपमा गर्छ, एक्सेप्ट अघि नै ज्ञानु म्यामले भन्नुभएको जस्तै PPE सेट र इक्विपमेन्टहरू किन्दाखेरि खर्च हुन्छ। र अर्को एउटा राम्रो कुरा के छ भन्दाखेरि मेरो कार्यकालमा HIV संक्रमितहरूलाई चाहिँ नेपाल सरकारको चाहिँ स्वास्थ्य बिमा निशुल्क रूपमा हुने बनाएका छौँ। सो त्यसले गर्दाखेरि यदि HIV को उपचार गर्दै हुनुहुन्छ भने इट्स फ्री अफ कस्ट। नेपाल सरकारको चाहिँ फ्री हेल्थ इन्सुरेन्स स्किममा चाहिँ HIV पोजिटिभ आर एलिजिबल फर फ्री अनि त्यसपछि आएर त्यहाँबाट चाहिँ वर्षको once a year 100,000 रुपिस सो इट्स अबाउट $900 त्यसरी चाहिँ त्यति अवस्थाको हामीले चाहिँ उपचार पाउन सक्छौँ र पोलिसीको कुरा गर्दा धेरै पोलिसी बनिरहेछ नेपालको विडम्बना के हो भनेपछि एउटा सरकार आउँछ एउटा पोलिसी बन्छ अर्को सरकार आउँछ अर्को पोलिसी बन्छ for current example in Nepal it's discriminated एउटा चाहिँ which is discriminated by Nepal government. WHO says that HIV is a chronic disease, but in Nepal the government of Nepal has announced 5,000 rupees per month scheme who are living with chronic disease, but they have excluded HIV positive in Nepal. So for example त्यसरी नै चाहिँ अवस्था हुने भएको हुनाले चाहिँ अलिकति चाहिँ पेशेन्ट सहित हामी सबै ताप्नुपर्ने अवस्था छ अझै पनि अलिकति नपुगेको अवस्था छ हुन्छ धन्यवाद am I able to explain?
Okay, thank you, Mr. Raj. Then another question is coming on my screen. Then it is a question asked for mentioned that for Ganu ma'am, but it is the question is related for the Mysore Mr. Gimire. Can you explain more about clearly about how there is a discrimination during menstruation in women with disability, Mr. Gimire?
Okay, thank you, Anup sir, and I would like to thank whoever raised this question. There are so many stories actually in that qualitative study, and which is a mixed study, and that is answered by the participants, and there are some qualitative stories as well. And let me share one of the story that belongs to one young girl with autism spectrum disorder, and her family shared her story that she is now in menstruation cycle, and when her menstruation cycle started, their family find themselves very hard to manage, and they decided to leave her in a room alone because their family has to go for the job and work, daily work, and she plays with her blood discharge the whole day at that room. So it means it's a discrimination, and it's a very inhuman kind of a situation, and we can imagine that. And other stories are there that people sharing their story about that their parents are wishing if their menstruation could be stopped somehow. So those are the stories that you can find on that report. And and another side, that the quantitative information that the individuals who are respondent of the study, they replied that the answer that they face discrimination somehow during their menstruation cycle from their family, in their family.
Okay, thank you, Mr. Gemire. It explained about more different issues are there, and he highlighted some case story also. So thank you once again. And another question is for I think it's for Rajesh. Why only indigenous group? What about the minority group living with HIV?
Okay, thank you again for a question. एकदम धन्यवाद प्रश्नको लागि. I will try to address both in English and in Nepali. For international audience, I will try to speak in English and in Nepali. नेपालीमा बोल्ने प्रयास गर्छु. Okay, minorities group को पनि including that, तर विशेषतः इन प्रोग्रामेटिक रूपमा रिसर्चको कुरामा चाहिँ सबैलाई चाहिँ एक ठुलो भाँडो बनाएर टाउकोमा बोक्न नसक्ने अवस्था भएको भएर चाहिँ पहिलो पार्टमा चाहिँ हामीले चाहिँ इन्डिजिनियस कम्युनिटीलाई चाहिँ इन्क्लुड गरेर चाहिँ हामीले चाहिँ यो बनाएका हौँ. यो एउटा देशमा मात्र होइन, 7 days इन 7 countries, 7वटा देशमा हुन्छ. त्यसपछि आएर माइनोरिटिजको कुरा गर्दाखेरि पनि हामीले त्यहाँ पनि छ. जस्तै नेपालमा माइनोरिटिजको कुरा गर्दाखेरि तपाईँको चाहिँ हामीले चाहिँ एचआइभी पोजिटिभहरूको कुरा यदि बच्चाहरूको कुरा गर्ने हो भने बच्चाहरूलाई चाहिँ जन्मेदेखि अथवा जन्मिन साथ चाहिँ नेपाल सरकार र ग्लोबल फन्ड एचआइभी प्रोग्रामबाट चाहिँ 1000 रुपियाँ पर मन्थ चाहिँ सहयोगको अवस्था छ। त्यसरी चाहिँ गरिरहेको छ, ट्रिटमेन्ट पनि छ, अनि त्यसपछि तिनीहरूलाई चाहिँ एजुकेसनमा पनि सपोर्ट गर्ने अवस्था छ। र चाहिँ यो विभिन्न खालको डाइभर्सिटी भएको हुनाले प्रोग्रामेटिक रूपमा त्यहाँबाट गर्न नसकेको अवस्था छ। सो त्यसले गर्दाखेरि चाहिँ अब नेक्स्ट स्टेप हामीले त्यो पनि इन्क्लुड गरेर लान खोजिरहेछौँ। त्यो भयो भने चाहिँ इट्स सो मच बेटर। त्यसले गर्दाखेरि तपाईँहरू सबैको साथ चाहिँ चाहिन्छ। So without your support, we could not do anything. So for that, we have to raise our voice and we have to speak out for a right, our rights, sexual reproductive health and sexual reproductive rights, health with rights. So this is the main theme of our research. So thank you. यदि प्रश्नको आन्सर दिन सक्यौँ भने.
Yeah, thank you. In the indigenous group also, my indigenous group are categorized in different group, minority group, and there is a different category. We'll address some issue. Just Raj highlighted that. And another question is I want to ask with Dr. Aryal. Different issues you are highlighted. You are working in a Cuban university, and you are also working in a education sector. So, is there any plan, policy, or activity for the from the education sector to address the SRHR of indigenous people living with HIV and related issues?
Thank you, Anusa. Thank you to the person who has raised this question. It's a very good question because, and this is the issue also. So far as I reviewed the literature, I could not find any policy which properly addressed the SRHR related issues of the indigenous women particularly. There are some policies now which are very progressive in terms of addressing the issues of SRHR, even in the educational policies like Education Sector Plan 2021 to 2030. This is a new policy which has thoroughly addressed different issues of students and basically the adolescents in the national education policies. But and there are some other policies in health sector also, like adolescent development strategy and other kinds of policies. But particularly there is no any issue raised in our national policies. This is the gap which we would like to fulfill through this research. Thank you, Anup sir.
Okay, thank you for all the panelists and all the participants who raised the questions. Now I want to close this question answer session and want to go forward for the webinar. So finally, I would like to request our colleague to give thanks and give some closing remarks to all the presenter, participant, organizer, and to all the teams. Mr. Rajan, it's time for you.
Okay, thank you, sir, for this opportunity. First of all, I would like to thank all organizing team, WHO, CAN, HRB, IBB network, as well as for this wonderful webinar. Sorry, and some problem in my camera. This is a very remarkable and memorable webinar because in previous year, Nepal has no any kind of that kind of webinar. Those who can highlight it or SRHR issues. So on this webinar, we are also discussing varieties of issues, varieties of problems, which can encourage us to work more hard in our community. So one thing I would like to add in my closing remarks, I am also worked in SRHR law in 2018. So many of things which can mention in WHO strategy or WHO challenges, there are some solution in our SRHR law. So if we include or we can adopt some points or some of issue on from SRHR, which can help us for implement our upcoming project. Definitely, the project activity or strategy of practice area has been sort out the main issues of indigenous dealing with HIV women's issues. So I would like to thank our team for project team for effective implementation of project activities. So end of my closing remarks, सबै नेपाली साथीभाइहरू जो चाहिँ यसमा सहभागी हुनुहुन्छ उहाँहरूलाई चाहिँ प्रजनन स्वास्थ्यको समस्या नेपालमा एकदम विकराल रूपमा छ। धेरै कुराहरू आइसकेको छ, त्यहाँ सरकारी डेटा छैन हैन, ल्याक अफ डेटा, अनअवेयर, अब एजुकेसन छैन, इन्फर्मेसन छैन, क्षमता अभिवृद्धिको कुराहरू छैन, यो धेरै प्रकारको समस्याहरू छ। त्यो समस्याहरूको लागि चाहिँ हामी सबैजना एकजुट भएर लाग्नुपर्छ र यो प्रोजेक्टले पनि हामीलाई त्यसमा चाहिँ सहयोग गर्छ भन्ने आशा गर्छ। ओके, थ्याङ्क यू अनुप सर, आई वुड लाइक टु क्लोज माई क्लोजिङ रिमार्क्स। थ्याङ्क यू।
Okay, thank you, Mr. Rajan. We are now we are in the closing of our webinar. Thanks, Rajan, for giving thanks to all and highlighting some issues about the policies which we have the government is planning and addressing these issues. All the document are we can find in our website, WHO guideline, find in the WHO website. You can see in the screen, and also get some more information from the CAN website, as well as in the WHO IBB network. You can get some international guidelines, policy, and practice, as well as our activity, our program activity also you can find from there. Finally, I would like to thank all of the participants again from my side. I'm grateful to be to be part of this beautiful event and beautiful activities, and I'm also working for the research. र साथीहरु, हामी यो रिसर्च काम गर्दैछौँ, यसमा चाहिँ क्वालिटी डेटा लिएर एउटा केही पोलिसीमा यो भएको इस्युहरूलाई चाहिँ हाइलाइट गर्ने कुराले हामी एक्सरसाइज गरौँ। अघि राजेश दाइले भने जस्तै सबैजना हामी जोइन भौँ, सबैजनाले काम गरौँ, एउटा ब्युटिफुल रिजल्ट निकाल्ने गरी भाइ हामी काम गरौँ। र फाइनली आई वुड लाइक टु थ्याङ्क्स वन्स अगेन WHO IBB network, Community Alliance and Network, shortly we can say CAN, for this for organizing this wonderful event webinar, and we can raise the issues about different disability, people living with HIV, SRHR, and all the issues which we have present in our country. And finally, I will say thank you, namaste from all. नमस्ते सबैजनालाई। अब सबैजनालाई शुभरात्रि, नेपाली साथीहरूलाई शुभरात्रि भन्न चाहन्छु। फर अल विल से थ्याङ्क्स, have a good day, have a good night for all. Thank you.
At the end, I would like to offer my gratitude to Indigenous International Working Group on HIV/AIDS, Indigenous HIV/AIDS Community, and Communities Alliances Network CAN, and all of you, the participant organizers, especially Ados, Patricia, and every individual who are involved in this webinar, particularly who have provided us huge important time to us. We feel delighted to associate with you, and especially thank you everyone on the behalf of EGWA, on the behalf of Suruat, and on the behalf of all organized in WHO, IBF, everyone. Okay, thank you so much. Namaste, Subharatri.
Namaskar, सबैजनालाई शुभरात्रि।
नमस्ते नमस्ते।